SAWC in the spring. It's really a joy for me. Gary has been an excellent partner over the last, 5, 7 years we've worked together. And his team has been incredible in really improving patient care. That's really what we're about, right? There's the business side of it, but at the end of the day, we're here to improve the health and welfare of patients with chronic wounds, and we really, can't lose sight of that greater goal. So I'm here with my partner, Juliet McBride. We'll introduce ourselves and I'll get into the meat of the draft LCD saga. Juliet will talk a little bit about what she's seeing on the provider clawback front, and then we can just have an interactive discussion as to your concerns and your thoughts and questions. So I'm a partner in the DC office of King & Spalding. I'm in the FDA and Life Sciences group, and I work on primarily reimbursement strategies for our pharmaceutical, medical device, diagnostics, and other types of clients, including the whole wound care skin substitute world. I've been in that space now for well over 10 years. I've been at the firm for longer than that. I've been in private practice for about 15 years. Prior to that, I spent my career, first part of it, in the government. So I had a federal clerkship, and then I went to the Department of Justice. I was a constitutional litigator, defended acts of Congress in federal court. And then I moved over to HHS, where I served as the acting general counsel of the department. So I was the primary legal advisor to Secretary Mike Leavitt and led an office of 500 attorneys in the Department of Health and Human Services. So a lot of what I do now is regulatory and reimbursement advocacy, because a lot of my former colleagues are still at the agency. I know how the inner workings of the agency operate, and I can advocate on behalf of my clients when things just don't go right for them, as very often is the case. So Juliet, I'll let you introduce yourself.
Hard act to follow. Thank you for having me here, Priya. She's amazing, and I'm very thankful that she's looped me in on a lot of this. I'm a partner in our Houston office, and I'm actually on our healthcare team. So while I work frequently with Priya, I really focus on healthcare providers. So especially in the post-acute care space, and especially in the space with respect to reaching the patient in the home. And everybody's like, what does that mean? It's more than Part B Medicare reimbursement today. COVID expanded the thinking about reaching patients in the home in a different way, and it's much more than telehealth. So the fact that we're here today is exciting, but it's also a new space with respect to some of these reimbursement practices that are coming out that don't quite understand these models yet. So there's a large amount of advocacy that goes on in this space from the federal and state level with respect to how to even license some of these different models. And in the appeals space, or in the evaluation space, if you will, from the payers, there's a significant amount of scrutiny as well. I'm sure you all know better than anyone. But in large part, it's because a lot of these payers don't have a fundamental understanding as to what's being done for these patients. They see a lot of these patients in skilled nursing facilities and might think that they can get all of their needs met there, but we know that's not the case. And so a lot of what we do is to help educate the contractors when we're working through appeals, when we're working on going up through various phases of the appeals, to ensure that providers can keep the money that they've rightfully earned, and help sort of manage any clawbacks that might occur. So we're in a heightened scrutiny space, especially as it relates to DME. Those are a lot of clients as well, and medical supplies. So with that, I'll turn it back to Priya.
All right, great. So the draft LCDs, I feel like I'm in that movie Groundhog Day, because we were here last year and we're here again. I really got involved in the LCDs when they were, although I was involved in 2022 when they were proposed for a few of our clients. It really took off when the LCDs of last year were finalized. And some of you may remember that it was only 3 MACs, CGS, Novitas, and First Coast. And they finalized a set of LCDs late in the summer, gave us a 45-day notice period, and basically obliterated coverage for a large part of the market, and limited applications to 4 applications per episode of wound care. So several of our clients got together and formed a coalition. We call ourselves the Medicare Access to Skin Substitutes Coalition, and we fought hard against those final LCDs. And we had a lot of good legal arguments, and in addition to going to the MACs and representing those concerns to the MACs, we also went to the very highest levels of CMS, all the way up to the deputy administrator, and expressed to him the really bad policy and bad patient care that was going to be going to happen if these were taken into effect. And then we went on the Hill, got some congressional support, but the really key piece I think that moved the needle was our preparation of a lawsuit. So I worked in the government. I am a trial lawyer in the early part of my career. On our team is the former CMS Chief Litigation Counsel. So the two of us went to the Deputy Administrator and said, we have prepared a federal complaint. We think that this policy is arbitrary and capricious. We think that inadequate notice and comment was given. And those arguments really won the day. And before the LCDs, literally days before the LCDs were going to take effect, the MACs pulled them back. And when they did pull them back, we expected there to be a true analysis of the issues at stake, a true effort to take into account all of the input from various stakeholders, clinicians, researchers, patients. But that wasn't done. And instead, surprise, surprise, on April 25th, we get another set of LCDs, draft LCDs, but not just 3 MACs, all of the MACs throughout the country. So curiously, what was going to be a very limited set of decisions is now going to be effectively a national coverage decision, even though it's technically not going through the national coverage decision process. So we have, I know you had a session earlier today about educating you on the LCDs, so I'm just going to talk about our main concerns with the LCDs, the draft LCDs. First of all, the definition of what a skin substitute is inherently inconsistent with how FDA regulates human cellular and tissue-based products, HCTPs, under Section 361 of the Public Health Service Act. As you all know, those products need to be minimally manipulated and for homologous use. And you don't need to go to the TRG to get a letter to market your products. All you need to do is satisfy that standard. But because of the Q code process that CMS has put in place, everyone now is going to the TRG to get a letter. Fine. But the TRG is never going to say you can market this product as a skin scaffold. They're never going to say you can market this product as something that's going to adhere to the wound and become part of the skin. That's not what is homologous use. But the MACs, on the other hand, have put in place, even though now they are not requiring a specific FDA regulatory pathway, they are still saying you need to have something that functions as a skin scaffold and adheres to the wound and becomes part of the skin. And that is inherently inconsistent with how FDA operates. Now, that is not new to HHS. When I was at the agency, Secretary Leavitt had a mantra, one HHS. We have all these different agencies within HHS, FDA, CMS, NIH, CDC, it goes on and on. We needed to act consistently. This controversy and inconsistency between FDA and CMS has proliferated, not only in this space, but in a lot of other spaces. It's a constant argument that I put forward with a lot of other clients as well facing these issues. But here, there is really a head-to-head direct inconsistency with what the MACs are going to require and what FDA is able to do with regard to HCTP, such that it's basically obliterating coverage for all HCTP products. So that's sort of one set of arguments. The second set of arguments has to do with who goes in the covered category and who goes into the non-covered category. I don't know about you, but I've looked at those lists and they make no sense to me at all. Okay, you've got 15 products in the covered category and over 200 in the non-covered category. They supposedly took a look at the evidence and analyzed it, but there's really no rational basis for how they looked at the evidence. The products in the covered category are older products. All the newer ones, the more innovative ones, are non-covered. They have not set out the clear basis and criteria for what kind of evidence you need in order to move from the non-covered to the covered category. This is the definition of arbitrary and capricious policymaking, and that is one of our key arguments as well. And then finally, the 4 application limit. I don't know where they came up with this. There was significant evidence presented during the last go-round with the LCDs last year that the 4 application limit was not based in any clinical data. In fact, the LCDs now rely on clinical data to promote coverage for some of the products that have clinical data with more than 4 applications for a particular episode of treatment, yet they continue to adhere to this 4 application limit. So again, it's not without any rational basis. it is arbitrary and capricious. We think that all of those arguments are very strong ones and really speaks in favor of the MACs starting from scratch. We are not opposed to a coverage policy that makes sense. This one does not make sense. All they did was take the one last year that they rescinded, repackage it a little bit, and issue it again. So I just came from a set of MAC public meetings. I testified at the CGS. I had colleagues testify at the NGS and the Noridian, and you know, there are more coming, and we're going to be at those as well. But we really need to have a united front telling the MACs that this is not only not based in you know, rational policy making, it's arbitrary and capricious, but at the end of the day, it's bad patient care. There's no way that those 15 products are going to be able to manage the entire Medicare beneficiary population in the United States. So there's a lot of work to be done here. We are again going to the MACs. We are again going to go to CMS, although CMS has made it clear that they want the MAC process to run its course. I personally think that that's the wrong approach here, because the MACs really need to be aligned with how proper policy making needs to proceed instead of just wasting their time. And then we're going to go to the Hill. And then when the time comes, we may in fact go to litigation again. So that's kind of where we are with the LCDs. And I don't know if any of you read Caroline Fife's piece today that was issued. I think she hit the nail on the head, because really what's going on here is Medicare is frustrated with the pricing and the payment and the spreads for these products, and rightfully so. I mean, their mission is to be good stewards of the Medicare Trust Fund, and is to not let not reasonable unnecessary medical care occur. The problem, though, is you can't deal with the payment issue by attacking coverage. They're getting at this the wrong way. What they really need to do is get a payment methodology for physician office and clinic utilization. They need to take the ASP data that they're now collecting and actually publish ASP payment rates. But they're not really taking those steps. And I don't know why they're not really attacking the root of the problem here that they see, and instead going about it in a way that's really bad for patient care. So that's our approach to the draft LCDs. Juliette, I welcome your thoughts on both the LCDs as well as how providers are dealing with some of these increased clawbacks that we're seeing.
Sure. Just two key observations based on what you were saying. First, going to the underlying policy that's coming out in these proposals right now. We're already seeing that application of these faulty policies on the reimbursement side of things. So we're seeing claims denials from the payers. We're seeing audits and clawbacks for these very exact reasons that Priya just articulated that they've put into these proposals, which is wrong because the proposals have not been finalized yet. And so there becomes a really important advocacy piece that goes on the payer reimbursement side too, which is very consistent with the argumentation that she's doing on the policy side for the overall coverage. The second key observation coming out of all of this as well, and we never hear it enough, and I hope that we can start articulating this more and more, goes to payment and cost. When you look at these patients who are able to maintain a normal life, who are able to not be in a SNF, a skilled nursing facility, for an extended period of time, who are not wed to some very expensive payment source under Medicare Part A, for example, in the hospital, for extended periods of time. You know, there's plenty of evidence displayed here today about patients who are not having readmissions into the hospital, patients who aren't having to go into the skilled nursing facility and can recover at home and actually are doing better after recovering at home. These are huge cost savings for every payer, because facility-based care, not that it's wrong, but it's expensive, especially for patients who don't need to be in that setting. So somehow these really important principles become lost when they start looking at a product. They just see these as products that are really expensive. They don't understand the science behind the why and how they're actually saving the program. So with that, turning it back to Priya.
So what can you do? What can we all do? June 8th is the deadline for comments to the MACs. I encourage all of you to submit comments to the MACs. They don't need to be extensive or detailed. You may want to advocate on behalf of your individual product and why your product is in the non-covered category, should be moved to the covered category. That's one way to go about it. The other way is just to talk about the general policy and why it's wrong and should be changed. But I highly encourage you to get your point of view in the record and heard, because that's really what's going to make a difference and move the needle here.
Really?
Yes.
It's not
Go ahead.
capricious and arbitrary? I mean, will the comments really move the needle a little bit?
Well, the more comments that come in, the more that we can then, to the extent that the MAC decide to finalize something that is improper and inappropriate by ignoring the comments, then take it up the chain and go to CMS and say, they ignored all of these comments. If we only get a handful, then we can't say everybody's against this, right? And even with the Hill, who are not that big on the details of it, what they see is, what do my constituents want? And if my constituents want this policy to go away, then that's what I'm going to do. So that's another area where you can get involved, is if you have connections with Congress, with members, with their staffs on the Hill, go to them, have a meeting, call them and say, this is bad policy and you need to call CMS and make this go away. They listen to you. They want to know how many employees you have in their jurisdiction. They want to know how much money you give them. They want to know all those details because they care about making their constituents happy, right? So that's another way to go about it.
So we should reach out to our local congressman.
Yes.
And we're talking June 8, 2024.
June 8, 2024. It is a 6-week comment period from April 25th. But you don't need to stop on June 8th. June 8th is when the comments, the written comments are due to the MACs, and the public meetings are still ongoing. The comments to the Hill can go well beyond June 8th, right? Because here's the time frame, in case you don't know. So the MACs are going to take these comments in and analyze them for a period of months. Now, don't hold me to this prediction, but in my experience with the LCD process, CMS requires LCDs to be finalized 12 months from the time that the draft LCD is proposed. So the MACs have a full 1-year period to either finalize the draft LCD or to pull it back. So we're talking April 25th, 2025. Given that an election is coming up, given what hot button topics this issue really generates, I don't think anything's going to happen before the election, and I really think the MAC is going to take the full period they usually do to finalize something. That's what they did the last go around. So I think we're looking at Q1 2025 when the policy may be issued again. And so we have a good lead time to really make our voices heard. We cannot, take our foot off the gas pedal. We got to keep the pressure on. That's really the important part.
Just one more thing to add on that too. There's an opportunity to loop in your provider community. I work with very large health systems across multiple states, and they're looking at issues with length of stay, and having bed capacity issues and losing money because patients are staying too long. And how can they rightfully transfer patients out, not to just a SNF, but into the home? And I think some of the facts that come out of the products that you are responsible for speak to this for the provider community too, and how to advance patient care outside of an actual facility. And to the extent you can pull in those sort of stakeholders, all the better, to kind of round out the narrative that this is not just the manufacturers, it's not just the distributors or the providers, it's the whole playing field.
So it would be important to get the hospital systems involved in this as well.
Anyone and everybody who treats patients with chronic wounds, who has an interest in having effective treatments that work, need to make their voices heard. And the more the better. Volume does speak here.
How would you suggest that we format the comments so that they're substantial?
That's a great question.
Can you repeat it?
How are we going to format the comments to make sure that they, are substantial and mean something? So I am in the process of putting together, on behalf of the clients I work for, sort of a template letter that, clinicians can send in and patients can send in. We are more than happy to share that with everyone here to get that information out into the field, into the public, so you guys can take that information, formulate your own language around the general concepts and send it in. Yeah.
Priya, one of the things I've noticed over the last 6 months is they put in place a rather elegant, might say insidious, system of where the responsibility has been distributed over a number of groups. The MACs basically look at CMS, CMS looks at Medicare in general, some of them even point to the FDA. So my point is that no one wants to claim responsibility.
Yeah. Well, as much as CMS doesn't want to claim responsibility, the MACs are their contractors.
And so
They
it
are
has to,
responsible.
it has
A
to
lawsuit
end
would,
with CMS.
yeah, CMS would be the defendant. Yeah. The
Question,
secretary.
question for
Yeah.
you. The CPT manual is licensed by Medicare. The CPT manual is a description of procedures. Okay. So this is now where they're using a description of a procedure to just define a device. Does their use of the CPT manual in this fashion violate their license agreement from the AMA, using it to define a product in this case? And we're not talking about HIPAA codes, we're talking about CPT codes.
Right, yeah, no, that's a great angle. I have not thought of that yet. I'm not sure if I have access to the license that they have. I need to look into that. But that is something we will look into. Yeah, so for this definition of skin substitutes where they rely on this concept of skin scaffolding, the source for that is how the AMA CPT codebook defines it. I have no idea what AMA CPT coding has to do with Medicare coverage. Like, there's no rational basis for why they took that piece of information and used it to define coverage. But, you know, that's a great point. We'll look into that.
I have two questions that I bet are on everybody's mind. Number one, the limit of 4 is really, as I understand, it's not a limit of 4. You have to do a letter of medical necessity or a modifier on the procedure, correct?
So they have changed their sort of out and out limitation of 4 in the last version of the LCD to something a little bit less blunt, I suppose. But any kind of policy whereby they don't rely on the medical necessity concept for a particular individual patient puts an intense administrative burden on providers. And that is not a place that we want to be, because any delay in care is bad for the patient, right? Yeah.
My second question is, how do pressure ulcers above the knee, or how are they impacted by this current?
Yeah, so that's a great question, and we get that a lot as to what about all the wounds besides DFUs and VLUs. Technically, the draft LCDs do not apply to pressure ulcers and other kinds of wounds. However, in my view, when you put a bunch of products on a non-covered list for DFUs and VLUs, and then you get a patient with a pressure ulcer, I'm not sure the MAC is going to cover that product for the pressure ulcer, even if there's no particular, you know, LCD or coverage policy right on point. So there's that consideration. The other issue that was brought up at some of the MAC meetings today was the ICD-10 diagnosis code list that's in the draft LCDs is woefully deficient. There are a lot of conditions for wounds above the knee that are not on that list. And the way the claims edits are set up in the MAC systems is they're going to look and see if you've got an ICD-10 code that's on the list, or if they're going to look at the Q codes that are, you know, applied to the patient, and then if those are, you know, in the system as covered, boom, you're covered. If not, you're not covered. And then you go through this whole appeals process, et cetera, the patient is worse off. So
But
that's
to
another
follow
area.
up on that statement, should our draft letters, especially some of us as providers, involve some of those ICD-10 codes to justify that? Would that be a good
Absolutely.
idea?
Absolutely. You need to let the MACs know that from a clinical perspective, we use these products to treat these kinds of wounds. Because honestly, like they didn't take enough comment and input from clinicians, from patients, from others who really know how this really works. And that really is the problem.
And you see the same thing on the clawback side. The people who are evaluating these cases are literally dealing with a set of standards that have been published that don't necessarily coincide with what's happening. But beyond that, there's a limitation as to how deep they can go in understanding what's happening with that patient, which is really a disservice because then they're not understanding the context within which to apply these different principles. Same thing on the reimbursement side.
To that end, the LCD says this applies to venous diabetic ulcer. But 3 places in the LCD says this LCD applies to all diagnoses codes. Which is it? It's called the skin substitutes for VLU and DFU, and in the text, that is sneaky, and it is intended to penalize the practice of medicine. Because I am a plastic surgeon, I am not a podiatrist. I do not treat venous leg ulcers, diabetic foot ulcers, except for the fact that I'm very smart and have smarter friends than other plastic surgeons and doctors who choose to do these things. I would not intuitively know to go read that LCD because I treat calvarial defects, open skull fractures, open humerus fractures, and compound fractures of the leg. And there is no guidance in the document other than one sentence buried in the document that says that this is, and they have already used that as a reason to engage in BRAC audits and UPIC audits against doctors.
Another great point, yeah, I mean, we're just the lawyers here, we're not clinicians. I would love to hear from all of you, and feel free, like, take my email address and let me know every inconsistency that you see when you are reading that draft LCD. I wanna know about it, so that we can put it in our comment letters.
And the fact that there is verbiage in this LCD just south of the scaffolding issue that says products made to cover and protect, which is how everyone with an amnion, probably that's how your TRG letter reads, is not a covered type of product. I think that that's something that if all of you in the room who have an amnion product need to focus on that de facto eliminates you as a covered product. So the fact that it says, you know, anyone that cover and protect, which is how almost every TRG letter reads in that category. So I'd like to hear your comment on that, please.
Well, I mean, that's one of our key arguments, is that they're essentially denying coverage for a whole category of products, which the clinical evidence has shown are effective at helping wounds heal. It's just bad patient care.
We had a question here, please be patient.
Could you speak to the LCA?
Yeah, so the LCA, from a legal perspective, doesn't actually have coverage policy criteria in it. It's not supposed to.
LCA, local coverage.
Local coverage article,
Yeah.
exactly, thank you. It is supposed to just be sort of information on coding and billing in support of the actual coverage criteria in the LCD. So that is why technically they split it up that way. At the end of the day, though, they kind of operate the same way. You know, we can make some of these legal nuance arguments when we're at the ALJ level in an appeal that this is an LCA, it's not the LCD. But when, you know, the initial denials happen, it's based on what's in the LCA. That's what gets programmed into the claim system with Medicare. Yeah.
Can I make a couple comments? One is that many of the sources of amniotic tissue, they're all tissue banks, but they also have human transplant programs. I think that the conversation with our congressman has to be different, because the amniotic tissues for those tissue banks actually underwrites the very high cost of human organ procurement. And it is a great damage to our system, which is the best system in the world, of kidney transplants. And we will actually cause significant harm to minority populations by not allowing the use of these amniotic tissues. There are earthquake effects by denying all the amniotic tissues, because the tissue banks they procure organs, and they have to underwrite that cost. And I don't think there's an understanding on the part of CMS of the implications of what they are doing. The tissue banks aren't procuring amnion because they want to procure amnion. They're doing it to underwrite the cost of liver, kidney, and heart transplants. And I think that in discussions with our congressman, that is something that is a game changer for them, because the cost of procuring those organs have gone up 30–40% over the last 5 years.
What is the volume of those?
Of organ transplants?
Yeah, what's the volume?
I will work with Gary and I'll work with Priya on getting that
brilliant.
information.
You need to write a letter.
That's brilliant.
I will write down the information. Doctors know better than write letters.
That's a brilliant point. That's a brilliant point.
Well, that brings up an important point. How do we in this room, everybody showed up and we greatly appreciate that, unify as a voice through Priya? So please just don't take your drinks and leave. I would appreciate if everybody would come together and at least unify through Priya, you know, this common voice. We all share these concerns, we all have this problem, and I would appreciate if everybody would, you know, funnel that to Dan's point.
Is there an entity that we can join and pay a subscription to in order to advance these concerns appropriately?
Yeah, no, great question. We have a coalition that we have formed of companies that are sort of leading the fight here. We also have individual clients who have engaged us on their behalf as well. So, I mean, happy to talk with you individually about what makes the most sense for each of you. I mean, if you've got a particular product that you want to move from group 3 to group 2, then we would probably need an individual engagement to help you with that. But if it's something sort of more general policy level, then, you know, we can talk about, you know, other aspects. If it's just that you need sort of templates on how to reach out yourselves, I mean, we can just provide those to you, I think, because we'll have those in hand.
I think I'll be public.
Yeah.
I would honestly recommend that every single one of you who have contacts in hospital-based systems, in university hospitals, I know some of us do here, reach out to them as they are seeing lower admission rates through these products. This is very important. It's not just us that need to reach out, it's the whole system that needs to reach out. And if they're not aware of this, we need to help them be aware of this.
To Dr. Saberi's point, I think there's an opportunity. The groups that are affected the most by this, which are the physicians and the patients, are really unaware that this is happening.
Right.
And we know that this disease state really affects minorities disproportionately. I think there's an opportunity for everyone to get together and create a public relations message out to the community. We did some research earlier today, and astounding the lack of knowledge that this is even happening and it will happen to them. You know, we need to push back on CMS and ask them, what will happen to those patients if mobile wound care can't take them in? 150, 200 a week coming your way. What will happen to them? How many amputations are going to happen? How many infections? How many deaths? CMS themselves have chronic wounds as one of the top 5 causes of mortality. This is their own data. We pushed back on them, and I think it has to come out into the public. It has to be a public battle, and that's how we're going to win.
We should talk more. At the end of this month, CMS is hosting like a health equity, like with their Office of Minority Health meeting for 2 days in Baltimore, covering these topics and really health inequity, right? To your point. And so they're important leaders within CMS is like focus on this area who will be there. And so it would be interesting to make sure that like these issues are really at the forefront as they're addressing ways to like ensure equity across the board.
Absolutely.
That's a priority of this administration, so it is an argument that we are going to pursue.
So Priya, beyond guiding people with templates on physician letters, which we think we need a lot of those, we need to talk about what can we give to patients? What can we really give to patients for them to very simply write a letter as well? Because a lot of these patients don't have a very high educational level, and so we've been trying to come up with like letters that the patients themselves, under the guidance of their physician can say, hey, we have this problem, I'm not going to be able to continue your treatment. Can you send a letter that looks something like this? Do you have any plans that we can be as a deliverable to our large wound care clinics?
Yeah, we can work on that as well.
And another thought that comes to mind is putting up a system for these providers to adequately capture testimony from their patients in a way that they can share, with appropriate consent, that they can record, just a recording when the patient comes in or when they're at the bedside. That's huge, and they don't have to actually write a letter. Then the reviewers have a voice, a person to it, as opposed to just a letter. So that's another idea too.
Kind of like testimonials.
Yeah, exactly.
So we could set up a portal where we could do like a limited size video testimonial from the patient. And
With
I'll put them
appropriate
there.
consents from the patient,
Sure,
that they
sure.
understand how it's going to be used. But I think
Okay.
that's really powerful if you're able to pull something like that together. And it speaks volumes. It gives action in ways that letters can't necessarily do. And it's quicker for these patients who can't write it, mail it, or email it.
Clearly we see that this is not just affecting us, this is affecting multiple levels of healthcare. So I think all of us need to take that responsibility since we're all here personally, because like Jay has mentioned, most of the community has no idea this is happening. Has no clue. So instead of coming out of here and just kind of doing our own thing, let's spread the message. Let's make sure we are proactive in this, all of us, because it affects all of us.